Good morning, everyone. I'm absolutely delighted to be here and to see you all this morning, but I'm even more delighted to present, to introduce my colleague, and more importantly, my friend. And I would say in many ways, my work spouse, Dr. Laura Hanks. She's going to be giving us a talk today on a century of sex, science, and gender. Dr. Hanks attended college at Mary Washington University and majored in history, which I think is very apropos for the talk that she's giving today. She then came to the University of Wisconsin, where she completed her MD, and then continued her training at the University of Rochester in obstetrics and gynecology. And currently she's leading the charge and providing in the gender affirming care clinic, where she provides HRT in compassionate and gender affirming care. So please welcome Dr. Laura Hanks.
All right, and Dr. Pennycup is here on his vacation, so it's so sweet, and thank you for that nice introduction and for being here today. All right, so as mentioned, I was a history major. I love history, and I think there's so much we can learn from history because a lot of people actually find it sort of boring and don't learn from it. But as the saying goes, history will inevitably repeat itself. So that's part of the reason that I wanted to give this talk. I also believe that we can learn from historical cases and issues and people in order to make ourselves better practitioners in serving our patients. So I challenge you all to think about the themes of this talk and how we think about sex and gender and how it relates to the experiences of our LGBTQ+ community today. What can we learn from history to do better and not stay the same? I'm going to give you a second to read through this quote. Take a sip of coffee. So I read this as almost like a warning. Things that we say and medical practices that we're doing right now today will appear outdated and possibly offensive in the future. I will do my best to be respectful to the past, present, and future. And if anything I say during this talk is incorrect or invokes feelings of distress, please let me know so that I can continue to improve moving forward. So there are many themes of this talk, including one person's experience with sex, gender, and who they are attracted to is very different from the person sitting next to you. This is also true of our patients who seek gender affirming care. There's truly no one size fits all. History is also a story, and like all good stories, there are heroes and villains throughout. As a person who supports gender affirming care, I recognize I will have some biases in this talk regarding who the villains and the heroes are. Are you intrigued yet? All right. All right, so history is all, sorry, no, we talked about that. All right, there's also a strong theme of humanity and our duty as doctors, nurses, and providers to listen to our patients in a non-judgmental way. Lastly, and most importantly, the theme of patient advocacy is seen time and again through every text that I read. Without the loud voices and persistent efforts of the trans community demanding to have their gender identities respected, there may not be the type of gender affirming care that we have today. All right, here's a list of my objectives. I'm going to mostly focus on the past century of transgender care. This easily could have been a 6-hour lecture, and I've had more fun preparing for it than I care to admit. But I'm really only going to be able to scratch the surface on all the hard work that's done to promote trans care over this time period. I'm inevitably going to miss some stuff and not be able to touch on all the topics and events that happened during the time, but I've tried to pick a few people and places that were impactful for the trans movement. And of course, we have to have disclaimers and disclosure slide. So of the terms some of the terms I'm going to be using are going to be considered outdated today, like in 2024. So I'm going to be using the terms used at the time and acknowledge that these are not preferable to what we use today. I also recognize that my lived experiences are not the lived experience of those who identify as trans and non-binary, and that I can also bring some bias to this topic. Here's a picture of my super vanilla family. Drive home that point. All right, so who is the first transgender person? In thinking about this talk, I thought a century was kind of a nice round number, but it turns out I probably should have just done a decade because damn, there's a lot of history here. And it's super fascinating. So there's evidence of transgender humans that exist across every culture, race, and class. And I just thought this was a nice quote to drive that point home by the current president of US PATH. I wanted to add this slide to recognize, as I said, that gender diverse groups are all around the world. For those of you that don't know, I lived in Samoa for 2 years, and during that time, I lived for several weeks with my sister Pearl, who is pictured here, and identifies as a Fa'afafine. Fa'afafines are described as the third gender in Samoa. They're born male, but are raised wearing traditional female clothing. This picture was taken when I returned to Samoa after I'd been gone for 10 years, and I actually ran into Pearl in a restaurant, and she was very mad at me because I didn't tell her I was coming back, hence the face. But she is sweet and lovely, and we do still keep in touch on Facebook. All right, terms. Any talk with transgender care is gonna have to go through some terms, but because we're doing kind of the history of this, it's gonna be a little thinking about some of the history of where these terms came from. I wanted to quote author Kit Heyman, who said, quote, "When we talk about trans history, applying any label to people from the past is a difficult balancing act between recording the terminology used in the place and time, avoiding perpetuating past violence by repeating slurs, and valuing the connect that people today feel with people in history." So really just summing up a lot more eloquently what I said earlier. As it turns out, gender and sex, much like gravity and breathing, are super complicated phenomenon. That being said, we need to be conscientious that new vocabulary is constantly arising, and it's our duty as medical professionals to be flexible, listen, and respect the terms that our patients are using. So gender comes from the Latin word genus, which means kind or type. So our society has this need to organize bodies into groups. Some cultures, as I mentioned, have 3 genders. But the important thing I want you all to realize is that gender is historical and that it changes over time. It varies from place to place and culture to culture, and that is contingent on many different and unrelated things coming together in a unique and particular way. Now, some might argue that sex might be just as much a social construct as gender. Regardless of that assertion, the sex of the body, however you define that, does not bear any necessary or predetermined relationship to the social category in which the body lives or the identity and sense of self of the person who lives in the world through that body. Think about that for a second. All right, John Money was a PhD professor of medical psychology and pediatrics who helped establish one of the first university-based gender clinics in the country at Johns Hopkins in 1963. He published a paper in 1955 introducing the concept of gender roles. Money stated that gender roles referred to, quote, all those things that a person says or does to disclose himself or herself as having the status of man or woman. Importantly, Money and his colleagues pointed out that gender role and orientation were neither a result of biologic sex nor a sign of mental health or illness, which in the 1950s was kind of a big deal to separate that from mental health. In 1964, psychiatrist Robert J. Stoller coined the term gender identity, which was meant to more clearly differentiate subjective sense of self from the behaviors associated with masculinity and femininity. Gender expression I put on here just because I really like this bottom slide, because I just think it's really kind of like a cutesy way to show that gender expression can really be however you want to express your gender to the world. All right, so transgender term, this is a term that came into more widespread use in the 90s, where we previously used terms like transsexual and transvestite. Transgender is now considered an umbrella term intended to include a wide variety of behaviors and identities that do not conform to the stereotypes of gender that's reinforced by the binary. Some people use this term to move away from their birth assigned gender because they feel strongly that another gender would be better for them. Others are looking to challenge the conventional expectations of gender put upon them. Again, going back to the idea of everyone's experience with gender is very different. Non-binary and gender diverse individuals are those whose gender expression is either outside of the binary of masculine and feminine or is different from societal expectations. And fun fact, the singular word they was voted as 2015 Word of the Year in the American Dialect Society. Who knew that was a thing? All right, Magnus Hirschfeld, who we're gonna hear more about later, but he understood the motivation for people to wear clothing associated with a social gender that differed from the one that was assigned to them at birth, AKA those who wanted to change their vestments or clothing. Hirschfeld believed that this was one of many sexual intermediaries, which also included homosexuals and intersex people. They occupied the middle spectrum between pure male and pure female. However, in the 1950s, the term transvestism usually meant cross-dressing or probably more like the transgender term that we use today. All right, so here we meet our first villain. When I Googled villain, this is the picture that came up, which I like just thought was kind of funny, but anyway, he's not so funny. But Caldwell was an American general practitioner who became interested in sex education after World War II. He wrote self-help pamphlets hoping to dispel old-fashioned attitudes towards sex. In the late 1940s, he became interested in the subject of altering sex. Hirschfeld actually first used the term transsexualismus in at least one of his essays, but Caldwell happily took credit for coining the term. To be fair, he was the first, it seems, to use the term in direct reference to those who desired to change their sex. Unfortunately, however, he characterized transsexuality as a mental illness resulting primarily from childhood experience. Caldwell went on to state that it should be criminal for a doctor to remove a person's healthy glands and tissue to alter their sex. He advocated for, quote, psychological rather than physical adjustment. In his article, he stated that, quote, transsexuals are individuals who are physically of one sex and apparently psychologically of the opposite sex. Transsexuals include heterosexuals, homosexuals, bisexuals, and others. A large element of transvestites have transsexual leanings, end quote. He also asserted that these individuals have, quote, a poor hereditary background and a highly unfavorable childhood environment, end quote. I've actually also given a talk on the history of eugenics in our country, and this felt very much like that time, that thinking in the 40s. We were really concentrating on kind of like childhood environment and all of that. So that kind of makes sense when you fit into like where our thinking was at that time, but obviously that's a whole nother talk. All right, so despite the fact that Caldwell provided few references to any scientific literature to substantiate his opinions, this article was frequently used in popular commentary into the 1990s. Womp womp. All right, psychological sex. In the 1940s, scientists who studied intersexuality would often speak of a person's deeply rooted sense of psychological sex. It was a term used by doctors and scientists to refer to the sense of being a man or being a woman and to distinguish it from biologic sex. They did not know if it was caused by chromosomes, endocrine glands, genitals, or the mind, but that no one could change an adult's psychological sex. Once it was established, a person's sense of being a man or a woman could not be changed through psychotherapy or medical interventions. Sexual orientation is who you are attracted to. It is not the same as gender identity. So inversion. This term came from Ulrichs, who was a German lawyer who had described himself in a letter to his family as, quote, a race of man-loving half-men, end quote, and of having, quote, a feminine soul confined in a masculine body. In other words, the desire for men had to be an intrinsically female thing, which is kind of an interesting take. One could not be 100% male, but also attracted to men, in his opinion. Ulrichs was not trying to explain the sense of gender, but appeared to be explaining what it felt like to be a man attracted to other men. Intersex individuals are those whose genes or gene expression grants them either ambiguous genitalia or biological features related to gonadal development that deviate from that male-female dichotomy. Previously known as hermaphrodism, and remember this term came from Greek and Roman mythology, where the son of Hermes and Aphrodite fell in love with a nymph, and their forms merged to depict a god having male genitalia with breasts. Intersex demonstrates that the biology of sex is a lot more variable than most people realize. Due to the villain of our story, David O. Caldwell, loudly proclaiming that, quote, no ethical surgeon should remove healthy organs, end quote, very few US doctors in the 1960s were providing gender affirming surgery. However, they were routinely removing healthy genitals and reproductive organs of intersex children before they were old enough to consent for surgery. Ooh. All right. So this word gained traction more in the 21st century, but can be thought of as a synonym for non-transgender. While the prefix trans means across, cis means on the same side as. Again, we should use caution with this word as it does reinforce the binary. Trans historian Susan Stryker encouraged us to ask how someone is cis or how someone is trans. It's hard to just use one catch-all term. It's kind of the take-home point there. Speaking of take-home messages, new vocabulary is arising continuously. So as medical professionals, we have this obligation to be flexible and listen and to respect the terms that our patients are using. All right, moving on to our cast of characters. So again, this is not an exhaustive list. These are just some people that kind of popped up a lot in my reading and that I'm gonna focus on that have contributed to transgender care over the last century. So Magnus Hirschfeld is our first character in the story. His advocacy goal was to stop police harassment for trans people by providing letters of support, helping arrange gender affirming surgeries specifically for trans women, and to create a network of experts who could not only help patients, but advance the science of sexology. The Institute for Sexual Science was the first in the world dedicated to the scientific study of sex. Hirschfeld's work centered around the idea of universal bisexuality, which was the idea that all humans contained elements of both sexes and therefore had the potential to alter their sexed appearance. In 1920, he published The Transvestites, a term, as mentioned previously, used to describe people who we'd probably use transgender for today. In his work, he connected trans and gay experiences, pulling from the idea of inversion that we also discussed earlier. Because this legacy of inversion meant that homosexuality and trans identity kind of remained entangled for the next several years and was sometimes even used as an excuse to deny trans people medical care on the basis that they were, quote, really just gay. So not ideal. In the 1920s and 30s, much of sex change experimentation was happening in Berlin. Hirschfeld pioneered arranging sex-changing surgery for patients. The first complete genital transformation arranged through his institute was for Dortchen Richter, who was, the term used at the time was male to female, but trans female, who underwent castration in 1922 and had her penis removed and vagina surgically constructed in 1931. Unfortunately, the moment of triumph soon ended. In 1933, Nazis destroyed the institute, setting its books and files on fire. Adolf Hitler himself called Hirschfeld a gay man and a socialist and, quote, the most dangerous Jew in Germany. Hirschfeld fled Germany, never to return, living in exile until his death in 1935. So you might have noticed that a lot's happening in Berlin at this time. So why Germany? While we had surgery and hormonal treatments available in the US in the early part of the 20th century, the reasons Germans took advantage of these treatments for transgender individuals was because of a strong vocal campaign for sexual emancipation that was happening in Germany. Hirschfeld in particular worked to remove the legal and medical obstacles for sexual and gender variance and allow those who requested to change their sex to live in their lives how they chose fit. Germany was using a new definition of sex to validate sex change surgery. In this way, the Germans of the early 20th century were modeling the importance of physicians advocating for their patients. Meanwhile, in the US, during the early 20th century, medical professionals, despite having these surgeries and hormones available to them, were spending very little energy or time on the idea of transsexuality. All right, our next character, I'm going to spend a little bit more time with Christine Jorgensen because it's just a very interesting story of the time. So Christine was born on May 30th, 1926 as George William Jorgensen Jr., the second child and only son of George and Florence Jorgensen, who were Danish Americans that lived in the Bronx. So quick side note, during the early years, I'm going to use the pronouns that George was using at that time, which is he, him. And then as he transitions to Christine, we'll transition to she, her. So George's father was a contractor and a carpenter, and his mother was a housewife. Jorgensen recounted a quiet childhood hid by inner turmoil. Little George often wanted to play with dolls of his own and admired his sister's long hair and dresses. He felt ashamed and confused and comforted himself with books and photography. In trying to behave more like a man, George was drafted right after the war ended and served as a clerk in the army. This was very common at that time for transgender or trans females who just didn't have the support. They would join the army because it was like, that's the manly thing to do. So kind of fits the story of the time. In 1948, Jorgensen read a book called The Male Hormone by Paul de Kruif. The book suggested that glandular secretions were responsible for masculine and feminine appearance, feelings, and behavior. This was a turning point for Jorgensen. Jorgensen felt that the science of human chemistry might be the answer to all his questions. He threw himself into the study of the available medical literature and enrolled in training as a medical technician. He then made the decision to start experimenting on himself. Jorgensen convinced a pharmacist to sell him ethinyl estradiol, claiming that he needed the drug for the doctor he was working for. Jorgensen took the hormones orally and soon noticed he felt rested, refreshed, and was having some sensitivity in his breasts. In Jorgensen's story, science was the only viable solution. Everything that I read about Christine Jorgensen, it just kept coming back to science. That was the only thing that was going to make her feel better. So in the spring of 1950, Jorgensen left for Denmark to visit friends and planned to head to Sweden to search for medical treatment. In summer of that year, Jorgensen found prominent endocrinologist, Dr. Christian Hamburger. It's probably pronounced Hamburg, but my daughter told me it was pronounced hamburger, so that's what we're going with. He agreed to experiment free of charge. Hamburger had never seen a sex change, overseen a sex change, but had a longstanding research program studying various types of hormones and their effects on the human endocrine system. But what's important here is that this doctor listened to his patient. He made Jorgensen feel heard and transformed their story to the language of science rather than making it a talk about sex and gender. The plan they came up with was for Jorgensen to take estrogenic hormones through injection and ingestion, and then present for physical exams, psychiatric exams, and urine specimens. Initially, Jorgensen found a new state of mental balance. However, the need to live as a woman was stronger than ever. Now, all Jorgensen could think of was the operation. Since the late 1920s, Danish surgeons had occasionally performed castrations primarily as the treatment for men convicted of sex crimes. The psychiatrist, Dr. Stirrup, who treated Jorgensen, explained, and I just had to add this quote, it's very cheeky, quote, "An American surgeon can operate on any organ in the body, including the brain, but no, he may not operate on the testes. That is a hypocrisy which the mature society of Denmark refuses to accept." Well. For some background, surgical sex reassignment began experimentally on animals in Vienna in 1912. The first attempts to transform people from one sex to another began in Europe in the 1920s. The first vaginoplasty performed on a trans woman was 1931, and the first phalloplasty performed on a trans man was 1948. The lack of gender-affirming operations in the US was mostly due to the lack of doctors willing to perform them, given the reports such as Caldwell's, but also due to the market economy and the lack of insurance coverage for elective procedures. This led to desperation for many patients. In one review of the medical literature published in 1965, 18 out of 100 trans females had tried to remove their own testicles or penis, and 9 had been successful. So that's 1 in 10 at that time. In Jorgensen's case, she found doctors abroad who were willing to treat her for nothing as part of their medical research. In September 1951, Jorgensen underwent surgery to remove her testicles at Copenhagen County Hospital. The following spring, Jorgensen went to the American Embassy and was able to successfully change the name on her passport to Christine to honor her endocrinologist, Christian, who first prescribed her estrogen, and she began to embark on a new life as a woman. In June of 1952, Jorgensen wrote her family to explain her change. She told her parents, quote, "Nature made the mistake, which I have corrected, and now I am your daughter." Later, while recounting her life story, Jorgensen would emphasize her lonely struggles, saying that the saving grace, struggles in the saving grace of science. She did not adopt the metaphor that was used later in the 1960s of a man or a woman being trapped in a male body, but instead referred to herself as lost between the sexes. She felt her issue was as much physical condition as it was psychological one. On December 1st, 1952, the Jorgensen story was the front page headline of the New York Daily prior to her return to the US. I think it's fascinating to really pick apart this headline. It doesn't just say man becomes woman, but it uses XGI. As I mentioned, that was kind of like the post-war representation of masculinity at the time. And then it goes on to say becomes blonde beauty, which represents the hallmark of 1950s like white female glamour. The story was also thought to catch public attention because it was an unusual twist on an age-old story of an individual striving to succeed against all odds. However, now remember we're in the atomic era, so some were starting to wonder if this was another area where science had overstretched its own limits. Just because science could triumph over nature, should it? American doctors began weighing in, often publicly, with crude comments such as, quote, "Jorgensen was no girl at all, only an altered male," end quote. This story highlights how many dealt with the new cultural shift in our society's representation of sex and gender. When Jorgensen returned to the US on February 12, 1953, she was met at the airport by a crowd of 350 spectators and news reporters. She was made an instant celebrity, but reports continued to struggle with how to portray her. They commented on her legs, her face, whether or not she had a beard, what her voice sounded like. Articles would often show, as this one does, pictures of Christine right next to pictures of George to allow readers to compare and contrast. Jorgensen would later recount that she had to become a super female. She couldn't have one single masculine trait because of this. Lastly, the Jorgensen story highlighted America's concerns around gender roles after World War II. Many women took on traditionally masculine jobs during the war, and now in the post-war era, some conservatives would often push the idea of the good old days when men were men and women were women, whatever the hell that means. Popular magazines during this time would describe the growing number of women in the workforce as a crisis in masculinity. What? That being said, it's hard to determine now how the public truly responded to the press. Some attacked American doctors who refused to provide sex change treatments, but others spoke out against the European doctors who had the audacity to perform these operations. In summary, Jorgensen's story brings together celebrity glamour with the Americans' unresolved tensions around individualism, science, gender, and sexuality. She told a story that humanized her and defended her right to pursue her own happiness. She pushed the public to recognize the status as a woman. She also pushed American doctors and scientists to reevaluate their ideology. Throughout the 20th century, trans people were active agents in shaping their relationship with doctors, not just passive subjects. Prior to the 1950s, there were rare stories of cross-dressing for those who identified as what we probably would know now as transgender. But in the 1950s, there was an explosion of press covering sex change stories and what surgery and medical treatments could entail. These stories were usually inspirational and highly informative. Jorgensen remained a public figure until her death in 1989. All right, this is a picture of Harry Benjamin, not Benjamin Pickus, just to be clear. It's because of the stash. Harry Benjamin was born January 12, 1885 in Berlin. He never planned to be a sexologist, and ending up in the US was totally unintentional. He began medical school in 1909 in a small town at the foot of the Swabian Alps. He moved to the US in 1913 to practice the new field of endocrinology. He returned to Berlin to work with Magnus Hirschfeld in 1920s at the Institute for Sexual Science. He first met Jorgensen at a dinner party in 1953. It was during that time he began to adopt the theory of bisexuality. He wrote that, quote, "Sex is never 100% male or female. It is a blend of complex variety of male and female components." In 1905, endocrine secretions were renamed hormones by British physiologist Ernst Starling. Hormones were described as chemical messengers released by endocrine glands into the bloodstream and acted on distant tissues and organs in the body. But much remained unknown, and that was extremely exciting to someone like Harry Benjamin. He recognized the ability of certain hormones could relieve distress and suffering of certain individuals who felt they belonged in the opposite sex that they had been assigned. Beginning in the late 1940s, Benjamin began to provide care for trans individuals by prescribing hormones, including one to Christine Jorgensen. During the 1950s, there were many vocal psychologists and psychiatrists who were less inclined to sympathy for trans patients. In fact, they loudly spoke out against these individuals. In Joanne Meyrowitz's book, she describes them as seeing transsexuals as not only mentally ill, but also willfully annoying. An article published in JAMA in 1955 by Warden and Marsh depicted transsexuals as attention-seeking exhibitionists, overly eager for approval. They went on to say, quote, "The state of urgency and impatience they indicated was not only inappropriate, but also frantic and desperate. They concluded that the problem pervades the entire personality and could not be cured by amputation of the genitals." So that's what Dr. Benjamin was up against. He responded to these two. I really struggled with an adjective for these two guys, but we'll keep it clean. He wrote to JAMA stating that they had, quote, "badly misunderstood or misinterpreted his work." It's also important to note that these scientific debates made it into the press in large part because of the Jorgensen story had increased public interest in the matter at the time. Though through the early 1960s, American doctors leaned more toward preventative psychotherapy, and those that advocated for surgery had very little support. While there was a new language regarding gender, it unfortunately resulted, at least initially, in conservative clinical treatment. Harry Benjamin published Transsexual Phenomenon in 1966. This was the first major work to define transsexualism in clinical terms and argue for compassionate treatment. Benjamin attempted to tackle the confusion of sex, sexuality, and gender. He wrote, quote, "There is hardly a word in the English language comparable to the word sex in its vagueness and its emotional content. It seems definite, male and female, yet it's indefinite. The more sex is studied in its nature and implications, the more it loses an exact scientific meaning. With this vagueness in mind, he went on to break sex into 7 components: chromosome, genetic, anatomic, legal, gonadal, germinal, endocrine, and psychological and social." Is that 7? That seems like more. Benjamin reiterated the idea of psychological sex we discussed earlier, stating that, quote, "The person in adult life should live in the sex of their choice. In other words, the psychological sex should be decisive. It was the doctor's responsibility to help transgender people live fuller and happier lives in the gender that they identified as their own." Following the decade of sex, drugs, and rock and roll, there was a new relationship between gendered appearance and biological sex that was popular in counterculture. Initially, scientists and doctors closely associated transsexualism with homosexuality in their attempts to classify individuals. This idea that the object of one's sexual desire was not necessarily a defining characteristic of one's gender identity, and one's gender identity was not necessarily a defining characteristic of one's sexuality, was a hard pill to swallow as we're going into the 70s and 80s. Transgenderism and homosexuality had been conceptually interrelated since the 19th century, but most felt that if a person changed genders, then they were meant to have heterosexual feelings towards the opposite gender that they had become. For example, someone that identifies as trans female should only be in relationship with males. Unfortunately, in the 1970s, the transgender political movement lost its alliances with gay and feminist communities that were irreparable until the early 1990s. There are several reasons for this. First, the removal of homosexuality from the DSM in 1973. And for those that don't know, DSM stands for the Diagnostic and Statistical Manual of Mental Disorders, and it's a handbook used by US healthcare professionals and much of other professionals around the world as the authoritative guide to diagnose mental disorders. With the removal of homosexuality from the DSM, the gay and trans communities no longer had that common interest of working together to convince medical communities that their conditions were not pathologic. Something else happened in 1973 that many in this room might remember with some sadness in your heart. While people who were in possession of a uterus gained the right to abortion, transgender medical needs were not viewed through the same set of ideals that won Roe v. Wade, the Roe v. Wade case, in large part due to emerging feminist position that was becoming more hostile towards transgender rights. I want to take a quick pause, side note, when talking about abortions. I think it's really interesting to note that at this point in US history, attitudes toward gender affirming surgery was extremely similar towards their attitudes towards abortion. And I saw this like in multiple texts that I read throughout, so I wanted to add this in here. Author Meyerowitz states, quote, both procedures pose questions of legality. Both raised issues over patients' control of their own reproductive systems. Both threaten the reputations of doctors who perform them. In both, desperate patients beg doctors for their help, and in both, doctors weighed the needs and rights of the patient against their own convictions and the risk of their careers. Author Susan Stryker also notes that, quote, transgender people, like people seeking abortion or contraception, wanted to secure access to competent, legal, respectfully provided medical services for a non-pathological need not shared equally by every member of society, a need whose revelation carried a high degree of stigma in some social contexts, and for which the decision to seek medical intervention in a deeply personal matter about how to live in one's own body was typically arrived at only after intense and often emotionally painful deliberation. So with this in mind, think about what I said earlier about history repeating itself. Yeah, let's leave you with that thought. All right, so 1973 continued. This is a big year, This was the first year that San Francisco Pride events forbid transgender people from participating. The rising hostility towards transgender people culminated that summer in an incident directed at Beth Elliott, who was a transgender lesbian singer. She transitioned from man to woman in her late teens. However, a lesbian separatist accused Elliott of sexually harassing her years earlier. This became possibly the first of an emerging feeling, helped by many feminists, that trans females were violators of women due to unwanted penetration into the women's space. That same year, the West Coast Lesbian Feminist Conference, where Elliott was one of the committee organizers, the keynote speaker, Robin Morgan, stated that there was a, quote, gate-crashing presence of a male transvestite who insisted that he was, 1, an invited participant, 2, really a woman, and 3, at heart, a lesbian. Morgan went on to emphasize that, quote, men who deliberately re-emphasize gender roles and who parody female oppression and suffering. He dares to think he understands our pain. We must not call him sister. No, I will not call male she, end quote. It was in this atmosphere that the first gender clinic at Hopkins closed abruptly in 1979. Also in 1979, Janice Raymond consolidated much of this anti-trans discourse circulating at the time into this feminist narrative. Unfortunately, this book, written here, has played a huge role in transgender political history, also providing as a source for the anti-trans movement. I do want to take a moment to state that there is some harsh language in this next quote, and this could be triggering to some, but I felt it was important to include as part of the anti-trans history to keep in this talk. Raymond states in her text, quote, all transsexuals rape women's bodies by reducing the real female form to an artifact, appropriating this body for themselves, end quote. She went on to state that the mere presence of male to females in a woman's space, quote, violates women's sexuality and spirit. Raymond further recommended gender reorientation for transsexuals. And in the words of the great Dr. Ronnie Hyone, if you're ever in a doctor's office where said doctor or medical professional offers reorientation therapy, run, don't walk to the door. Because data shows that that's going to be harmful to our patients. The reorientation therapy does not work. The worst part is that this chick didn't quit. She reissued her book in 1994 with a new introduction stating that transgender people attempt to falsify reality. So if you ever find yourself wondering why people like this have certain views and opinions, now you know. Okay, back to some less heavy stuff. After Harry Benjamin published Transsexual Phenomenon in 1966, his friends and colleagues got together and formed a fan club. Just kidding. They formed a group. They said, let's name the group the Harry Benjamin International Gender Dysphoria Association, or HBIGDA. The association was eventually renamed the World Professional Association for Transgender Health, or WPATH, which is still very active today. It became the main organization for medical, legal, and psychotherapeutic professionals who worked with transgender populations. Membership consisted of surgeons, endocrinologists, psychiatrists, and lawyers that provided healthcare and conducted research. After a decade of research, they developed the first standards of care for gender-affirming care in 1979. These SOCs gave diagnostic criteria for transsexualism, which appeared in the DSM-3 that was published in 1980, which was the first edition published with the removal of after the removal of homosexuality in 1973. Transsexualism was then replaced by gender identity disorder, or GID, in the DSM-4, which was released in 1994. GID framed the experience of gender in the mind of dissociating it from sex of the body. But for all intents and purposes, it's still a mental health disorder. Unfortunately, this puts trans people in a tough place because now it's a pathology, but healthcare plans in the US would not cover treatment because it's considered elective, cosmetic, or even experimental. Given all these events in the 70s, the transgender communities became more inwardly focused in the 80s, which was unfortunate timing because that's right as the AIDS pandemic was hitting. Of note, the most current DSM, SOCs, and ICD codes attempt to use language that is meant to non-pathologize the gender identities, while at the same time allowing us to provide needed care for these patients. All right, so going into the 90s, there was a tremendous burst of new transgender activism in the early 1990s due to several of the historical events that I've listed here. A number of states came to recognize legal sex change on birth certificates and driver's license. Some states had rights for post-op transgender people to marry in their current gender, including Wisconsin. In 1995, many formerly gay and lesbian organizations began adding T to their titles, shifting the nomenclature to LGBT community. In 1999, the website Remembering Our Dead first launched to spotlight anti-transgender violence that left 1 to 2 trans people dead every month since records had started being kept. This led to Transgender Day of Remembrance, which has become an annual opportunity to spotlight anti-trans prejudice and violence. By the end of the 20th century, trans people began to have a greater decision-making power over their own lives, as well as which surgical techniques they preferred, or to even have surgery at all. In 2007, the first piece of federal legislation ever to address transgender concerns, known as the Hate Crimes Bill, passed both the Senate and the House. RuPaul's Drag Race has been a constant presence since 2009, and we also saw a large amount of publicity akin to Christine Jorgensen when Caitlyn Jenner came on the scene in 2015. During the Obama administration, we saw truly unprecedented advances in civil rights for trans people. This was thought to be as a result of changing social attitudes that were finally being reflected in the highest parts of government. Obama relied on executive orders to advance transgender rights, which included amending requirements for changing name and gender on identity documents and forbidding discrimination against LGBT people in federal employment. Okay. But one of Obama's most significant and albeit controversial accomplishments was the passage of the Affordable Care Act in 2010. This health bill made it illegal to discriminate in the provision of health care and thus legally necessary to cover medical transition costs for trans people seeking gender-affirming care. Vice President at the time, Joe Biden, said in 2012 that ending transgender discrimination was, quote, the civil rights issue of our time. In 2014, Denise Mallon, a 72-year-old Vietnam veteran, successfully sued the UC Center of Medicare and Medicaid Services for denying gender confirmation surgery. This win lifted a 22-year-old ban on the procedures. In 2016, it seemed that the lives of transgender people were on the cusp of full legal equality. The transgender rights movement experienced extreme setbacks after Trump's presidential victory in 2016. But as trans author Susan Stryker eloquently states, quote, "If there is a lesson to be learned from US transgender history at the dispiriting moment in which these words are being written," she was writing in 2017, "it is that trans people have a long record of survival in a world that is often hostile to us." In Lauren Schechter's textbook on gender confirmation surgery, it is also stated that, quote, "Over 100 years later, there are still no definitive answers to questions concerning what makes someone trans, but certainly more is known about how to effectively treat those who experience disabling gender variants." So because we know that our trans patients are going to keep fighting for their rights, I believe it is our duty as clinicians to also fight and advocate for the rights for them to live in whatever gender they see fit. And I quickly wanted to just let you know about some great resources out there. UCSF is actually where the president of US PathWorks has put out fantastic guidelines for all things transgender. So I'm sorry if you can't see, it's like super tiny print, but these are screenshots from the webpage. Literally, if you type UCSF transgender, this will be the first thing that comes up. And all of these blue things that you can click on. So like anytime you have a transgender patient and you're like, I tell them to stop smoking. That's a bad example. Like what's their risk of like if they've had a DVT or something like that? They have this on the site. And if you want to do hormone therapy, they literally give you how to start. I did the testosterone one. There's also one for estrogen too, obviously. How to start, what's your initial dose, typical dose. And then on the left side, it shows you how to do the labs, how to follow up, when to follow up, and what you're looking for. And then it'll go through on that page, like what to do if things are abnormal. So it has been in this new clinic, it has been kind of just always open on my laptop. And it's just a great resource for all of you to know. And then also WPATH. The mission of WPATH is to promote evidence-based care, education, research, advocacy, public policy, and respect in transgender health. The standards of care were just recently published. That it was SOC 8 that just came out. For those like old school like me, I had to have the printed version because it's about 270 pages, but there is a PDF online version that you can have access to as well. Special thanks to all the transgender doctors that have helped me kind of coming in here and helped me get the clinic off the ground. Callan Smith, who runs our clinic at MDC and helped me get my newer clinic off the ground too. And it's just been a great source of support. Katie O'Brien also helped me with some of these slides, who's going to be helping teach the residents on transgender care. Amy Domeyer, my boss, puts up with me. My husband also puts up with me. My mom's my #1 fan, as always. And these two monsters, keep me sane. And last but not least, my boomer dad. So we're going back to 1973 again, big year, big year. He did his thesis in college on what would happen with mousing nesting habits when they injected them with estrogen and testosterone. So he believes because of this, he's actually the grandfather of transgender care. So big year for everyone. It probably didn't get more published or publicity just because of everything else going on. I'm sure it would have otherwise. So these are my works cited, fantastic books I'm happy to send out to you guys. This is just a picture I like to add for gender expression. Despite my scowl, I was like super pumped to give out getting to wear a tie. I was like really, really into that at that age. And it was the 90s. Like people were letting, gender expression was starting to become a thing. So there you have it. Thank you guys. Any questions? Hope you're all awake. Sorry. Any questions online? Actually, can I see that? Empty, okay.
Thank you so much. That was really interesting and informative. Um, I am curious about, you mentioned that the current language for ICD codes and the DSM and everything try to walk that fine line between not pathologizing, but still giving medical authorization. And I just wondered if you could talk a little more about how that's worded and how that's navigated, I guess, with patients who might have come to a clinic n- that requires, psychological counseling and letters from a therapist and all
Yeah.
that sort of stuff.
That's a great question and something I didn't talk on, just didn't have time to add, but there is still the ICD code of gender dysphoria. And that is meant for patients who are truly experiencing dysphoria due to their gender. So, or to their sex assigned at birth. So they feel dysphoric because of that. Some people don't as much have that dysphoria. So you'll still see that diagnosis a lot of times when they're seeing early on going to therapy and kind of working through those feelings. I personally try to use when I'm doing with like gender affirming hysterectomies and getting those letters, I'll often use gender incongruence just to say it just there's like a lack of matchup. And so having a uterus doesn't fit with who they are. You're right. We do have to get the 2 letters of readiness from therapists in order to do the hysterectomies, but I've only so far had pushback from one insurance company. It was because someone screwed something up, basically. And it was very easily fixed. So when you have those 2 letters and you kind of follow those guidelines, and I mean, appropriately counsel, right? Like we're not just taking out organs willy-nilly. Like I have a very long discussion with patients. They've had a long discussion with their family medicine doctor, with their therapist. By the time they get to me, they've already had these conversations a million times. But it is my duty to, as a surgeon, go through it and go through what a surgery is. The surgery is a major surgery, in fact. So the risks that are associated with that as well.
So you talked about Obamacare and transgender care. Why do you think that, if you recall, when Obamacare went through, the big debate was whether abortion would be covered, and abortion is not covered? Why do you think that a decidedly female procedure was excluded, and like very pointedly excluded?
Yeah.
And transgender care was included in Obamacare?
That's a great question that I think honestly has a lot to do with like them just like having to give up some things for other, and for, it's all about like who's in the House and who's in the Senate at that time and who was gonna like give on some of those things. They're both, that's why I put that slide in there about abortion, because they're both very polarizing things and they're similar. So it is, you bring a great point. It is very interesting that it wasn't included, but in short, I don't know, but I have a feeling it had to do, like, as I'm learning more about how legislation works, that there was probably some Republican that was okay being fine with that and not.
I just wonder, what role do you think that fundamental sexism in our society and, kind of an okay
Yeah.
attitude, permissive attitude toward
Right.
controlling women's bodies versus
Yeah.
something that affects both genders or both
Yes.
sexes
Yeah.
Is more permissive, is more
Right.
something that you would accept to not be legislated?
Again, just making assumptions. I think it just comes down to like, but the babies, like it's like having that control of this potential life. Whereas with transgender care, it's one person. I also, just to, going back to like just fundamental sexism, I just found all the reading about kind of the feminist movement and the hostility towards transgender care in the 70s and 80s. And that to some extent is still around today to a lesser point, I think did do some damage with that like rift there, where everyone should have been working together for a common goal. So I wonder if that in some ways plays into it. But I do think that, yeah, there's absolutely a portion of sexism. And I think that transgender care, again, has been more in the news recent, like I think since like the Trump administration. I feel like in 2010, it was kind of more like, oh, it's not that frequent, it's kind of fine. It's like people weren't paying as much attention as they are now. I have a feeling if that tried to pass today, it probably wouldn't, like, you know what I mean? Because of all the stuff about like transgender youth and stuff like that. So sorry, I don't have a great answer. Just like from my readings, like kind of my thoughts, but yeah, it all kind of sucks. Really. So, oh, I think that Callan, so Callan also just posted their email in the chat for anyone that's interested. Callan's just a great resource for if you notice in your clinic not having a lot of like gender neutral language or needing like rainbow flags and stuff like that, or trainings for like your front desk staff. I think a lot of our clinics have that, but for others that are listening, Callan comes in, like gives those lectures, and they're amazing at it and can help. I've actually like taken pictures of our clinic waiting room and sent them to Callan. Like, so it's just like a lot of like pregnancy stuff. Like, how can we make this more kind of gender neutral? And I think that was in response to Molly Lepik, local resources for clinicians in isolated systems, so smaller clinics, rural docs, et cetera. I think that, you know, within the UW, Callan would also be helpful with that. And I'm, you know, also happy to talk. I think it is hard for our rural patients. We have a lot of patients that come in from rural communities and have just some really sad stories about how they were treated. So doing more outreach is really important. I think for our rural residents, I usually have a pronoun slide on here, you know, always like kind of wearing your pronoun badge and helping other providers in outside areas kind of see you getting to model that language and those attitudes as well is super important. And I think it's always hard when you're a resident, right? Like that power dynamic, but I think that you can do that in a respectful way. We've talked sometimes about like when a patient's under anesthesia and the anesthesiologist is using the wrong pronouns and just kind of very subtly saying, well, it's actually he, him, or they, them. You know, just because the patient's asleep, you should still use the correct pronouns, like out of respect. So I think that you can do that in a non-abrasive way, just very subtly, like, oh, just actually, and you know, people are like, oh yeah, sorry. Thank you guys.